Let's talk a little about the prostate cancer and its treatment, diagnostics and classification. So we have the subtopics: etiology of the prostate cancer, risk factors of the prostate cancer, epidemiology, histological classification, diagnostics of the prostate cancer, and the treatment of the prostate cancer. The etiology. The prostate cancer is always polyetiological disease. The risk factors of the prostate cancer are age, ethnicity, hereditary, geographical, nutrition, and climate. Epidemiology. The prostate cancer is one of the leading causes of the malignant tumor deaths in older men worldwide. More than 83,500 new cases of this disease are detected each year in European community, which accounts for about 9% of all male cancer deaths. Every 17 minutes, one man dies on prostate cancer in the United States. In 2001, the disease was the leading cause of the death for about 3,150 men. The mortality rate from the prostate cancer in Canada is about 25 per 100,000 of the male population. Epidemiology of the prostate cancer has the high increasing of the cases from the 1991 and still is in the high position for nowadays. Here we can see the statistics in all countries where we have the prostate cancer diagnostics. So the most affected nationality are Africans and African Americans. Geographically of the prostate cancer, here we can see that we have less people with the prostate cancer in the Europe and in Asia. Epidemiology of the prostate cancer, the incidence in Ukraine in 2005. The 16,000 cases of the prostate cancer are detected for the first time. The first highest incidence rate. The prevalence rate about 20 per 100,000 male population, and average annual increase is about 8%. Actually, for nowadays, it is even higher due to the situation with the modification of the methods of the diagnostics and also the treatment. The epidemiology of the prostate cancer become higher due to the more accurate methods of the investigation, but the deaths from the prostate cancer become lower. Histological classification of the prostate tumors. So we have epithelial tumors which are benign and malignant. Malignant are adenocarcinoma, transitional cell carcinoma, squamous cell carcinoma, and undifferentiated cancer. The histological classification of non-epithelial tumors which are benign and malignant. Malignant are rhabdomyosarcoma, leiomyosarcoma, and other. The diagnostics of the prostate cancer includes the digital rectal examination, PSA, transrectal ultrasound of the prostate, and biopsy of the prostate. Here we can see the macroscopic picture of the prostate cancer with the foci of the adenocarcinoma, which are laying in the tissue of the prostate. The diagnostics of the prostate transrectal ultrasound. We can see the contours of the prostate gland and the changing of the hypoechogenesis and the contours of the prostate gland on the peripheral part of the tissue. So here we can see that the tumor comes spreading out of the prostatic capsule, which means that it is T3. The diagnostics of the prostate gland includes also the PSA investigation of the blood, which should be about up to the 4 nanograms to the milliliter and may be in the gray scale up to the 7 or 8 nanograms to the milliliters. In cases if it is higher, we should do the biopsy of the prostate gland. So here it is the diagnostics of the prostate biopsy with using of the biopsy tool, which has the own needle, and also the transrectal ultrasound tool, which is connected to this biopsy needle. The prostate biopsy makes from the 12 points. Actually, we have the 10 in the prostate gland and also the 11 and 12 in the seminal vesicles. There is a little changed the picture, but we made the 12 point the biopsy. 11 and 12 are vesicles, seminal vesicles. The prostate biopsy, how it looks like, we will see.
Your doctor has recommended an exam of your prostate with a transrectal ultrasound and prostate biopsy. Before we talk about this procedure, let's review some information about the prostate and why these tests may be necessary. The prostate is located under the bladder and behind the penis. It is a walnut-sized gland that is part of the male reproductive system. It helps make semen. The urethra is a tube that carries both urine and semen to the penis. It passes through the prostate, which surrounds it like a donut. If you are scheduled for this procedure, your surgeon is concerned that you may have prostate cancer. Prostate cancer is the most common cancer found in men. At most risk are men age 50 and older and those with a family history, especially a father or brother with prostate cancer. But at highest risk are African American men and men over age 70. Usually there are no early signs of prostate cancer, but some men have problems with urination or pain that warn a physician that more testing is needed. Prostate cancer screening can help physicians find prostate cancer early before a patient has problems and include the digital rectal exam, or DRE, where a physician examines the prostate for lumps by placing a gloved finger in a man's rectum, and prostate-specific antigen, or PSA, is a blood test ordered for some men based on their age and risk factors. Routine PSA testing is not recommended after age 70. A prostate ultrasound with biopsies is done to test for cancer when a nodule or lump is felt. It is also done for a high PSA and for some problems, especially with urination, that can be a sign of prostate cancer. With an ultrasound, your surgeon is able to scan and measure the prostate without X-rays or radiation. The ultrasound also guides the needle used to biopsy your prostate. The tissue biopsies are sent to a pathology lab for examination. The next steps for your care are discussed after the procedure and with the final lab results. This may take 1 to 2 weeks. If cancer is found, the lab will give the tumor a number called a Gleason score, which is a grade of how abnormal or aggressive the tumor cells look. DNA gene testing is commonly done on the tumor cells as a new way to measure how aggressive the tumor is. This is different than a cancer stage, which is based on where, how large, and if the tumor has spread. Treatment decisions for prostate cancer are based on many factors, including a patient's age and general health, the cancer Gleason score, DNA results, and stage. A biopsy can be false negative. That means the biopsies did not find prostate cancer that was there. 30% of men with prostate cancer, about 1 in 3, will have normal biopsy results from the first procedure. A second procedure with more biopsies is done to search for prostate cancer if a PSA stays high and cancer is strongly suspected but was not found with the first set of biopsies. Sometimes MRI, magnetic resonance imaging technology, is used with the ultrasound to help find or target a tumor for biopsy. Ultrasound-guided prostate biopsy tends to be a short procedure, available at many hospitals, and is the most common procedure used to biopsy the prostate. MRI technology uses magnetic coils to get detailed information about the prostate and possible cancer. MRI is very expensive, takes longer to do, is newer and still being studied, is less available, but is helpful in managing difficult cases. Now let's talk a little more about what happens during a transrectal ultrasound and prostate biopsy. To start, you are positioned comfortably. Most patients are awake for this procedure. An ultrasound probe is coated with lubricant gel and gently placed into your rectum. The gel helps the probe to be more comfortable for you and is needed to get clear ultrasound pictures. The size and shape of the prostate is checked and measured by gently moving the probe near the prostate. Numbing medication is injected near the prostate to decrease the discomfort of the biopsies. The ultrasound probe is used to guide a needle biopsy device to take about 12 tiny pieces of prostate tissue. You will hear a snapping sound with each biopsy. After the biopsies, the ultrasound probe and needle are removed. This procedure is done as an outpatient. That means you will go home the same day as the procedure.
So here looks like the prostate biopsy, and we have also the transperineal type of the prostate biopsy, but it is more difficult for the technically making and also more dangerous, in my opinion. So transrectal will have not so big complications after this, and also due to the cheapest usefulness of the tool with ultrasound only and biopsy needle, we can do this in any hospital in Ukraine or in other countries. So the treatment, the choice of the treatment method depends on the stage of the process. So the treatment includes the systemic treatment, surgical and radiation therapy. In systemic are hormonal therapy, targeted therapy, chemotherapy, immunotherapy, radiopharmaceuticals, and bone-modifying drugs. The surgical treatment includes radical prostatic, open prostatectomy, robotic or laparoscopic prostatectomy, bilateral orchiectomy, transurethral resection of the prostate gland. And radiotherapy includes external beam radiation therapy and brachytherapy. So here our external beam radiation therapy.
How the linear accelerator works. All body cells can be damaged or killed by radiation, but tumor cells are more sensitive to radiation than normal cells. Radiation therapy uses this principle to damage beyond repair or kill the abnormal cancer cells in a tumor. Successful radiation therapy depends on the ability of the linear accelerator, or LINAC, to deliver a tumoricidal dose of radiation to the tumor, while ensuring minimal radiation of normal tissue. The LINAC accurately produces, monitors, controls, and conforms the radiation beam to the planned target. Beam generation. Radio frequency waves are pulsed into the waveguide by the magnetron. This is synchronized with the injection of electrons into the waveguide by the electron gun. The radio frequency waves accelerate the electrons along the waveguide to a speed approaching the speed of light. The X-ray beam is created when the electrons hit and interact with a tungsten target at the opposite end. The magnetron controls the power and frequency of the radio frequency waves, which determine the energy of the X-rays produced. The digital accelerator uses a diode-type electron gun situated at the end of the waveguide. The electrons are produced by heating the tungsten filament within the cathode and are then injected into the waveguide. The number of electrons injected is controlled by the temperature of the filament. The electrons are accelerated along the waveguide toward the target. The waveguide contains a series of copper cells. Small holes, or irises, between these copper cells allow the electrons to travel along the waveguide and help to focus the beam. A vacuum is created to ensure that the electron beam is not impeded by other particles. The path of the negatively charged electron beam is controlled by two sets of quadrupole magnets, called steering coils, that surround the waveguide. An additional two sets of focusing coils help to further define the electron beam so that it is very fine, with a diameter similar to that of a pinhead when it hits the target. The entire system is cooled by water. The electrons exit the waveguide and enter the flight tube, where the beam is redirected towards the target. The electrons travel along a slalom path within the flight tube. Three pairs of magnets on either side of the flight tube cause the electron beam to bend through the turns of the slalom. This process not only positions the beam to strike the target, but it also further focuses the beam to a diameter of 1 millimeter. The design of the magnets enables them to focus electrons of slightly different energies onto the same point on the target. This is called achromatic behavior. This slalom bending is unique to electrolinear accelerators. It helps to minimize the size of the machine and ensures that its isocenter remains low, which is important for patient setup. The high-energy electrons hit a small tungsten target where the electron energy is converted into photons, or X-rays. The high-energy photons emerge from the target in a variety of directions. The primary collimator only allows forward-traveling X-rays to pass through, creating a cone-shaped beam. The primary collimator minimizes leakage, and therefore excess total body dose, by absorbing scattered X-rays traveling in the lateral direction. It also defines the maximum size of the resulting clinical radiation beam. At this stage, the photons are not uniformly distributed across the beam, and so a flattening filter is placed in the path of the beam. The cone-shaped filter absorbs more photons from the center of the beam than from the sides, creating a uniform photon beam. Dose measurement. The photons now pass through the ion chamber for dose measuring and beam quality monitoring. The dose delivered to the patient is measured and controlled simultaneously in two independent ionization chambers. One chamber is the primary dosimeter. It measures the radiation and terminates the beam when the required dose has been delivered. The secondary ion chamber acts as a backup and will stop the irradiation if the primary chamber fails. The treatment machine must replicate the beams modeled within the planning system. This is critical to the accuracy of treatment delivery. A beam quality function is performed by a third ionization chamber, which uses 7 electrodes to monitor different sections of the radiation field. The X-ray beam is almost ready to treat the patient. Before that, further beam shaping is required to ensure that the shape of the delivered X-ray beam matches the shape of the tumor. This is done using a multi-leaf collimator, a number of fine tungsten leaves which move independently of one another and can create a variety of complex treatment shapes. LINAC control. One computer system controls both the LINAC and the multi-leaf collimator. This eliminates dosimetric errors due to communication delays. It also ensures synchronization between the delivered dose and the multi-leaf collimator position, allowing complex deliveries such as intensity-modulated radiation therapy and volumetric modulated arc therapy. All electromagnets, steering, and focusing coils are digitally controlled. All mechanical positions of flight tube, filters, and foils are automatically selected from the control console, and all radiation beam settings are grouped in calibration blocks for each energy. These are stored digitally on the Linux hard disk for flexible and easy beam adjustment, calibration, and servicing. Clearance. Clearance is the free space available under the LINAC for patient treatment, and it varies with different protocols and fixation devices. It is a combination of the distance between the lower surface of the radiation head and the isocenter, 45 centimeters, and the head diameter, 62 centimeters. A wide clearance around the isocenter means improved access for patient setup, freedom to use the best possible patient positioning and immobilization accessories, freedom to rotate the gantry between fields without needing to move the patient. Finally, it means that treatment techniques using non-coplanar beams are not compromised. The large clearance offered by Elekta machines ensures flexibility in providing the best possible treatment for the patient.
And let's see the difference between the brachytherapy and how it is doing by the specialists.
Elekta's real-time prostate solutions were developed with one goal in mind: to offer you real-time workflow for prostate brachytherapy, in which the treatment is provided in a continuous session. The real-time prostate solution seamlessly integrates real-time imaging, adaptive planning, and state-of-the-art treatment delivery. A high-resolution 3D visualization of the prostate and surrounding tissue can easily be generated with the unique ECRM device. Guided by the Oncentra treatment planning system, it operates the ultrasound probe to automatically capture sagittal images. The probe remains in place throughout the entire procedure so that you will have live ultrasound images readily available for real-time planning. State-of-the-art contouring tools make contouring of the prostate and surrounding tissue very easy, accurate, and fast. Examples are the envelope to contour the prostate and the sweep to contour the urethra. When contouring is finished, you are ready for treatment planning. The real-time prostate solution calculates the best possible virtual plan using presets that you have entered based on your clinical objectives. Advanced planning algorithms allow the software to quickly generate the treatment plan. With traffic lights for your presets, you can evaluate the plan dosimetry at a glance. The needle navigation technology helps you to insert the needle in the planned trajectory. Simply select the needle you want to insert, and the probe will automatically be rotated to the correct plane. As a result, you can follow and guide the needle insertion live on the ultrasound image. Once in place, simply reconstruct the exact needle position and update your plan. Can you adjust the plan if the prostate position changes after the needles are inserted? Yes. In the event that organs have moved or the prostate is swollen, you can capture an up-to-date image set at any time. Your plan can easily be adjusted to the actual situation. In a few simple steps, you can contour the new status. The traffic lights will clearly show you the consequences for your plan. The real-time prostate solution allows you to visually evaluate the treatment plan at any moment based on isodose lines, cold and hot spot location, or traffic lights. The seed or dwell positions can be adjusted, and the traffic lights will again show you the result. For delivery of HDR prostate brachytherapy, the needles are connected to the afterloader. This device transports a radioactive source into the needles to the planned dwell locations and radiates the target area. For prostate brachytherapy with seeds, the seed selectron transports a seed train into each of the needles. Plan optimization based on the actual situation can be done after each seed train insertion. It
provides a real-time workflow with true adaptive planning. The Realtime Prostate Solutions offer you a truly integrated and fully dedicated solution for prostate brachytherapy.
So now you can understand what types of the radiation therapy we can prescribe for the patient with the prostate cancer. See what the types of the let's see what the types of the therapy we can use more. So it depends on the localized form of the prostate cancer. If we have the localized form, we can use also the radical prostatectomy, radiation therapy, also techniques under development of the like cryotherapy, laser therapy, high intensity ultrasound. The most popular in the world is the laparoscopic laparoscopic Da Vinci radical prostatectomy by robotic surgical intervention. It is more accurate, and also the doctors with a good experience can do this operation the best. So let's see how they do it.
You have been diagnosed with prostate cancer. Your doctor has recommended you to undergo a robot-assisted radical prostatectomy, or simply RARP. A radical prostatectomy is a surgical procedure where all of your prostate is removed. This animation shows how the procedure is done. RARP is carried out under general anesthesia. During a general anesthetic, medications are used to send you to sleep, so you are unaware of the surgery. When you are fully sedated, small cuts are made in your belly. Surgical tools and a camera are inserted through these cuts. The surgical tools are attached to the arms of a robot. These arms are controlled by the surgeon with a console, which is placed next to the operating table. The surgeon detaches the prostate from the surrounding tissue. The seminal vesicles, two small fluid-filled sacs next to your prostate that secrete fluid which partly composes the semen, are also detached. Sometimes the lymph nodes, commonly known as glands, are removed also. The surgeon will take care to cause as little damage as possible to the nerves and blood vessels surrounding the prostate. The prostate and seminal vesicles are removed from the body through one of the cuts in your belly. The bladder and urethra are now sutured together. Robot-assisted surgery provides a clear visualization of even the smallest parts in your body. A catheter is inserted in your bladder to help the stitched-up wound to heal. The catheter removes urine from your body. You will be wearing it for a period after you have left the hospital. It will remain in place by inflating the balloon at its tip. RARP is a major surgery from which your body needs to recover. You will suffer for a while from urinary incontinence, which in most cases is temporary. You may also suffer from erectile dysfunction after the surgery. Talk to your doctor about what can be done to overcome these complications.
And let's talk a little about the systemic therapy which includes the hormone therapy like bilateral orchiectomy, LHRH agonist, LHRH antagonist, androgen receptors inhibitors, androgen synthesis inhibitors, and combined androgen blockage and intermittent hormonal therapy. So bilateral orchiectomy. Bilateral orchiectomy is the surgical removal of the both testicles. It was the first treatment used for the metastatic prostate cancer more than 70 years ago. It was, even though this is a surgical procedure, it is considered hormonal therapy because it removes the main source of the testosterone production, the testicles. The effects of this surgery are permanent and cannot be reversed. Bilateral orchiectomy is not commonly used in the practice. Like LHRH agonists. There stands for luteinizing hormone releasing hormone. A medication known as LHRH agonists prevent the testicles from the receiving messages sent by the body to make the testosterone. By blocking these signals, LHRH agonists reduce the man's testosterone level just as well as removing his testicles. Unlike orchiectomy, the effects of the LHRH agonists are often reversible, so testosterone production usually begins again once treatment stops. However, testosterone recovery can take from 6 months up to the 24 months, and for a small number of the patients, testosterone production doesn't return at all. And LHRH agonists are injected or placed as small implants under the skin. Depending on the drug used, they may be given once a month or once a year. When LHRH agonists are the first given, testosterone levels briefly increase before the falling in the very low levels. This effect is known as a flare. Flares occur because the testicles temporarily release more testosterone in response to the way LHRH agonists work in the body. This flare may increase the activity of the prostate cancer cells and cause the symptoms and side effects such as bone pain if the cancer has spread to the bone. Next one is LHRH antagonists. This class of the drugs, also called a gonadotropin-releasing hormone antagonist, stops the testicles from producing testosterone like LHRH agonists, but they reduce testosterone levels more quickly and do not cause the flare associated with the LHRH agonists. The FDA has approved the Garelix, like Firmagon, given by the monthly injection to treat advanced prostate cancer. One side effect of this drug is that it may cause a severe allergic reaction. An oral LHRH antagonist like Orgovyx or Relugolix, it is also approved by the FDA for the treatment of advanced prostate cancer. Relugolix is different from the other LHRH antagonists in two ways. First, it has a lower risk of causing serious heart problems in patients with the pre-existing heart disease. Second, when the treatment with Relugolix is stopped, testosterone production is restored within weeks rather than months, which may be helpful for those undergoing intermittent hormonal therapy. Next one is androgen receptor inhibitors. So while LHRH agonists and antagonists lower testosterone levels in the blood, androgen receptor inhibits block testosterone from the binding to so-called androgen receptors, which are chemical structures in cancer cells that allow testosterone and the male hormones to enter the cells. In effect of AR inhibitors stop the testosterone from working. The older AR inhibitors include biculotamide, flutamide, and nilutamide. Are taken as pills. Never AR inhibitors include apalutamide, duralutamide, and enzalutamide. These medications are also sometimes called anti-androgens. AR inhibitors are usually given to people who have castration-sensitive prostate cancer, which means that the prostate cancer still reports response to the treatments that lower testosterone levels. AR inhibitors are not usually used by themselves to treat the prostate cancer. Then androgen synthesis inhibitors. Also, the testicles produce most of the body's testosterone. Other cells in the body can still make small amounts of the hormone that may drive cancer growth. These include the adrenal glands and some prostate cancer cells. Androgen synthesis inhibitors target the enzyme called CYP17 and stop cells from making the testosterone. And combined androgen blockage. Sometimes androgen receptor inhibitors are combined with the bilateral orchiectomy or LHRH agonist treatment to maximize the blockage of male hormones or to prevent the flare associated with the treatment with LHRH agonists. And intermittent hormonal therapy. The traditionally hormonal therapy was given for the patient's lifetime. During the past 2 decades, researchers have studied the use of intermittent hormonal therapy, which is when therapy is given for specific times, most commonly 6 months, and then stop temporarily to allow for testosterone levels to recover, for these patients hormonal therapy is restarted when the PSA begins to rise again. When the restart therapy that is at PSA levels is still off topic of the debate, using the hormonal therapy in this way may lower the side effects related to the lack of the testosterone and to improve person's quality of life. So we also have the side effects of the hormonal therapy. They are erectile dysfunction, low sexual desire, hot flashes with sweating, gynecomastia, depression, cognitive dysfunction and memory loss, heart problems and heart disease, weight gain, loss of the muscle mass, and osteopenia or osteoporosis, which is thinning the bones. And chemotherapy, docetaxel plus hormonal therapy, abiraterone with the prednisone or prednisolone plus hormonal therapy, apalutamide plus hormonal therapy, and enzalutamide plus hormonal therapy. So let's talk a little about all these types of the chemotherapy. So docetaxel plus hormonal therapy. In those with a very widespread disease who are able to receive chemotherapy, docetaxel combined with the hormonal therapy may be recommended. Docetaxel with or without prednisolone is given by 4 months every 3 weeks for a total of 6 dosages. The side effects of the docetaxel may include low levels of blood cells, infection, nausea, vomiting, muscle aches, and hair and nail changes. It may also cause the peripheral neuropathy, which is the type of nerve damage that causes a tingling or burning feeling in the hands and feet. Abiraterone with the prednisone and prednisolone plus hormonal therapy. This treatment is recommended for newly diagnosed high-risk metastatic castration-sensitive prostate cancer, but it also can be offered to people with low-risk disease. The apalutamide plus hormonal therapy, this combination was proved in 2019. It offers a treatment plan that doesn't need long-term treatment with steroids and frequent monitoring with laboratory tests. This treatment is recommended as an option for those with metastatic castration-sensitive prostate cancer, regardless of the risk of or volume of the disease. And enzalutamide plus hormonal therapy, this combination was approved in late 2019. It doesn't need treatment with the steroids and frequent monitoring with laboratory tests. This treatment is recommended as an option for those with metastatic castration-sensitive prostate cancer, regardless of the risk or volume of the disease. So there are the most often types of the therapy, diagnostics, and the treatment of the prostate cancer. Thank you very much for your attention. See you up on the next lesson.